Hi, welcome back to the IU Radiology Case of the Day. My name is Tim Tsai, and I'm a fourth-year resident at the Indiana University School of Medicine. Today, we've got an interesting abdomen case. I'd like to give a shout out and thanks to Dr. Hill for her help, and of course, Dr. Coons for organizing the entire Case of the Day initiative. All educational content has been fully de-identified to protect patient privacy. For history on this case, we have a patient experiencing abdominal pain and hemorrhagic pancreatitis. Here are the images. On the left, we have an axial contrast-enhanced CT during the portal venous phase, and on the right, we have coronal reformat through the kidneys. Take a moment and look at the images. Alright, now, what are the findings? What's your differential for this case? And what is your diagnosis? Let's go over the imaging findings. On the axial contrast-enhanced CT image, we see extensive peripancreatic fluid and stranding reflective of their history of hemorrhagic pancreatitis. We see other things like ascites and pleural effusions on the coronal reformat. Of note are both kidneys, which enhance in an atypical manner. The cortex is poorly enhancing, while the medulla enhances in a more normal manner. The renal cortex has a thin, subtle peripheral rim of enhancement just deep to the serosa. We can also appreciate these findings on the coronal reformat. Again, the cortex demonstrates poor enhancement compared to the more normally enhancing medulla, and there's also a thin peripheral cortical rim of enhancement. This is a case of renal cortical necrosis, which is a form of acute renal failure from severe hemodynamic compromise and derangement of flow to the kidneys. This causes ischemic necrosis of the renal cortex while sparing the medulla. Acute renal cortical necrosis is essentially caused by anything that results in that acute and prolonged hemodynamic compromise, such as hemorrhage, shock, sepsis, trauma, postpartum complications, transfusion reaction, snake bites, pancreatitis, hemolysis, burns, etc. The reason is postulated to be related to a combination of vasospasm and/or intravascular thrombosis. Acute renal cortical necrosis is often an irreversible process with no specific treatment aside from addressing the underlying hemodynamic insult. Eventually, the necrotic areas can calcify, which would spare the medulla and cause cortical nephrocalcinosis, and the kidneys become atrophic. On ultrasound, renal cortical necrosis can appear as a hypoechoic circumferential band. On CT, there is preserved enhancement of the renal medulla with non-enhancement of the cortex. This is the reverse rim sign. There can also be a thin cortical rim sign reflective of preserved capsular flow from a capillary network that freely anastomoses with other retroperitoneal arteries and perforating arteries, making a thin millimetric rim of preserved cortical capsular enhancement. Delayed clearance of contrast is also seen. On MRI, renal cortical necrosis essentially appears as decreased signal of the cortex on T1 and T2. This is not to the level of hemosiderosis, but normally the cortex is brighter on T1 than the medulla. On T2, differentiation between cortex and medulla is usually difficult, but this differentiation is exaggerated from the decreased signal of the cortex on MRI during renal cortical necrosis. For those of you performing angiograms on the kidney, there can be an unusual, diffuse, and abrupt termination of vascularity at the interlobar and arcuate artery levels. This causes irregular scalloped perfusion defects of the renal cortex. As for the differential, lymphoproliferative disorders such as leukemia and lymphoma may manifest as hypoattenuating or low signal areas infiltrating the kidneys, but the distinct signs and clinical features of renal cortical necrosis make differentiating the two possible. Hemolysis secondary to paroxysmal nocturnal hemoglobinuria, sickle cell anemia, and mechanical hemolysis, such as from leaky heart valves, can cause hemosiderin deposition in the cortex, which causes markedly low signal on MRI, but not so much low attenuation on CT. For more reading on classic signs in uroradiology, I'd recommend this paper by Dyer and Chen and Zagoria. Or, if you'd like to read more on atypical low signal intensity of the renal parenchyma, I thought this paper was good too. So to sum it all up, for acute renal cortical necrosis, severe hemodynamic derangement results in ischemic necrosis of the cortex, with sparing of the medulla, and presents with a reverse rim sign and possibly a cortical rim sign from preserved capillary network. Preserved medullary enhancement is characteristic, as is delayed contrast clearance from renal failure. Eventually, the infarcted cortex can calcify. On MRI, renal cortical necrosis demonstrates low signal on T1 and T2, although not to the degree of hemosiderosis. So as always, thanks for tuning in to the IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and you can check out our complete collection of Case of the Day materials at the link below. Thanks so much and have a great day.